If you are a pediatric feeding therapist or interested in pediatric feeding therapy, please listen. There is very limited research when it comes to pharyngeal dysphagia in pediatrics. And some of the biggest reasons are the fact that it's a vulnerable population. From an ethical standpoint, it's really hard to get IRB approval to say, hey, we want to try out this intervention that may or may not work for a child or may cause harm, or there's certain risks involved. And so we have to, in pediatric dysphagia, rely a lot on adult literature to kind of help guide it. But kids are not just small adults. There is a lot of differences that come into play here. For example, there are certain interventions that have very limited evidence, but after providing informed consent and collaborating with the family and the medical team, I am more likely to implement as compared to others, even though the research is equally limited based on the science that we do have. So for example, doing oral trials with a child versus NMES, neuromuscular electrical stimulation. In both of these situations, research is very, very limited. But when we look at a risk to benefit analysis, we look at the literature that we do have and always make sure that we're getting informed consent, letting the family know of those limitations, collaborating with the medical team to really determine the best plan of care. I am going to consider oral trials, but NMES is just not one that's going to be implemented into my practice. And if you really want to look at a deeper dive into how to critically think through these research limitations and still make treatment selections in pediatric dysphagia, then check out the course I'm doing with Dysphagia Cafe. Comment dysphagia below for more information and a link to register. In the meantime, let me know your thoughts about this topic. It's a tricky one and I'm open for discussion.